Hi, welcome to K-Medicine. This lecture is a continuation of the previous one in which we had an overview of clinical anatomy of anterolateral abdominal wall. In this lecture, we will study about abdominal hernias and their different types. We will study about a few basic clinical concepts of neurovasculature of anterolateral abdominal wall, and finally about abdominal incisions in different procedures. So let's get straight into it. Abdominal hernias. Before I tell you about abdominal hernia, I would like to tell you what a hernia is. A hernia is a protrusion of part or whole of the contents of abdominal cavity through a potential weakness in the wall that normally does not occur. There can be multiple causes of herniation of the tissue. Firstly, you should know that there is positive pressure in the abdomen. So, if there is a weakness superiorly in the diaphragm, it would lead to upward bulging of the content down their pressure gradient. Similarly, if inferiorly or anterolaterally or posteriorly there is any weakness in the wall, it would lead to bulging of the content due to positive pressure of abdomen. That is the normal design. But why do some people develop hernia and some don't? Because there are several other factors involved too. These include a natural weakness in the wall due to the normal anatomy. For example, the linea alba is naturally a weakness in the wall of abdomen. Similarly, the inguinal canal through which the testes descend is naturally a weakness. Other causes are developmental failures, as occurs in umbilical hernia of neonates, as we will discuss in a bit. Other causes include collagen disorders or muscle disorders or excessive intra-abdominal pressure due to any reason. There are certain parts of a hernia, as you can see here in this picture. We have a mouth through which it protrudes, a neck, which is the narrowest part, a sac that has the contents. Contents of hernia can be anything. It is different in different types of hernia, as we shall see. So, there are 4 different abdominal wall hernias that we will be discussing today. An umbilical hernia, an epigastric hernia, spigelian hernia, incisional hernia. First of all, umbilical hernia. Neonatal umbilical hernias are common in premature or low birth weight babies. The umbilical defect is present when a baby is born because of the umbilical vessels passing through it. It normally closes within a week, but if there is a failure in development, it would lead to herniation of abdominal tissue. Most of these hernias resolve spontaneously though. Sometimes, in obese women, acquired umbilical or para-umbilical hernias may also occur. This might be due to congenital gaps in the muscle fibers coupled with other factors like obesity, or pregnancy, or aging. Second type is epigastric hernia. An epigastric hernia occurs through the linea alba, that is the midline raphe. It can occur anywhere between xiphoid process and umbilicus. An epigastric hernia, occurring just above the umbilicus, is also called a supraumbilical hernia. Most of the times, they only contain extraperitoneal fat. They can reoccur. Another rare type of hernia is a spigelian hernia. These usually occur in the 4th decade of life, may be related to obesity. One point to remember is this, that they occur along the semilunar lines. As you can recap from this picture, the region that I have highlighted with green is mostly the region for spigelian hernias to occur, but it can occur anywhere along these lines. It results from a defect of spigelian fascia. Spigelian fascia is basically the aponeurosis of transversus abdominis muscle. Lastly, the incisional hernias. These occur due to the musculofacial defects caused by incisions. They occur around the post-operative scar. There are a number of factors for it. Delayed wound healing is one of them. Endoscopic surgery has shown reduced incidence of incisional scars because a smaller incision is made. Here, we are done with abdominal hernias. Now some basic concepts about the neurovasculature of abdomen. We know that the nerve supply of abdomen comes from lateral and anterior cutaneous branches of thoraco-abdominal nerves and subcostal nerve, the ilioepigastric nerve, the ilioinguinal nerve. These supply the muscles of anterolateral abdominal wall and the overlying skin as well. The first applied concept that I want you to know here is, when we palpate an abdomen with cold hands, the muscles reflexively become rigid, the phenomenon known as guarding. This guarding is exaggerated when any organ inside the abdomen is inflamed. Like in appendicitis, this is actually a clinical sign to pick appendicitis. As a general rule, the abdominal palpation is done in supine position with semi-flexion at thighs and knees. Superficial abdominal reflexes are observed in different neurological examinations to check the integrity of abdominal nerves. There is a reflex contraction of the muscles which is felt by hand when the skin is stroked. About nerve injuries, you should know that surgical incisions are the most common cause. This can lead to paralysis or weakening of the muscle, which can obviously lead to hernia formation. But due to overlapping innervation, some loss of fibers may go unnoticeable. Now, another important topic is abdominal incisions. It is very simple. But before I go into different types of incisions, I want you to know some basic principles. Incisions are made according to the muscle fiber direction and orientation. These fibers then can be split but not transected because that would lead to muscle damage. But rectus is an exception because its fibers are short. Now coming to different types of incisions. There are 3 types. There are longitudinal incisions, oblique incisions, and transverse incisions. Just look at this picture over here. At this level, you should know which incisions are made in different surgical procedures. Firstly, longitudinal ones. These include 2, median and paramedian incision. Median or midline incision is made along linea alba for any kind of exploratory procedure. There are few blood vessels and nerves, so there is minimal bleeding. But it also means delayed healing. Paramedian incisions are made in sagittal plan along the anterior layer of rectus sheath. Now coming to oblique incisions. Gridiron incision or oblique incision or McBurney's incision is made for appendectomy. It is made 2.5 cm superomedial to anterior superior iliac spine at the McBurney's point. In this, the external oblique is retracted, and the internal oblique and transversus are split. Important point is, ilioepigastric runs deep to internal oblique and it is to be taken care of in appendectomy. In transverse incisions, suprapubic incisions are important and are made in obstetrical and gynecological procedures. Subcostal incisions are made when we deal with gallbladder or spleen. Thoracic 7th and 8th nerve is preserved. Lastly, there are 2 high-risk incisions that you should know. Number 1. Pararectus incisions, which are made at the lateral border of rectus and it may cut the nerve supply to it. Second is inguinal incisions due to the danger to ilioinguinal nerve. Just an important applied concept here. Obstruction due to any reason in superior or inferior vena cava results in formation of anastomosis or collaterals in their tributaries such as the thoracoepigastric veins or superficial epigastric veins. These can be visualized in thin patients and it is actually a clinical sign for caval obstruction. That's all about applied anatomy of anterolateral abdominal wall. We will be discussing inguinal hernias in the next topic. Thank you for watching.